Elder mistreatment as a cause of death. I mean, I thought, well, maybe the doctors of living patients, we're a little behind, you know, and we don't have a really good ICD-9 code for that. And then I had the opportunity to work on a paper with the chief medical examiner from New Mexico. And it's not happening. In fact, in Houston, the medical examiner over the last 5 years has only determined 3 cases as being caused by abuse or neglect. Now, since we started lecturing to them and working with them, those numbers have increased, but you can figure out why. How do you tell the difference between particularly when the patient is dead, but you know, what's normal aging and what was a result of abuse or neglect? How do you really make that distinction? Okay, so which of the following examination findings is most suggestive of abuse? Skin tears, hip fracture, ulnar surface arm lacerations, or unexplained weight loss? Okay. Most suggestive. Elder victims of sexual abuse often have significant cognitive impairment. True or false? 3. An elderly patient presents with a history of multiple falls and long bone fractures over the past 18 months. Which of the following would be most helpful in differentiating abuse from physiology of aging as the cause of her fractures? CT scan, bone scan, total body radiologic survey, or bone density scan? Well, what we're going to do today is sort of go through a head-to-toe review and talk about, compare and contrast what's normal aging, and then what you can, when you see it, what you can, at least it's suggestive of elder abuse. Basically, if any time you have a gestalt, you just have an idea that something's not right, you obviously should suspect it. I'm sure everybody here, you have an interest in it, but there was a teaching when I was in training is that if you don't think of it, you can't make the diagnosis, so you can't find it. And that's obviously true in elder mistreatment. And you know, head-to-head examination, head-to-toe examination is really important. There was a case recently of a woman who came to the hospital. She was not primarily an English speaker, and she said her daughter was abusing her. Now, her daughter, by the way, was a volunteer in the gift shop, right? Like a nice, I mean, this is a giving person. And the patient was, a little bit, it was hard to communicate. So the residents called me and they said, my attending said I have to give you a call, Dr. Dyer. This doesn't sound like anything. And I said, well, did you examine all of her? Did you take off all her clothes? And most of it we did, they said. Okay. What's her many mental state score? I said. We heard about that earlier. And they go, well, we haven't done that yet. Okay. And I said, and if the woman is alleging that she's been beaten, have you done any radiology tests? Have you done any x-rays?
no, we haven't quite done it yet. And so they did. And what do you think they found? Well, first of all, her mini mental state score was 16, which meant that she was somewhat demented. So that threw something in the works, right? I mean, is she just saying this? Is this a delusion? The daughter, the lovely daughter who volunteers in the gift shop of the public hospital. And then they did take her clothes off fully and examine her, and she had a big bruise on her trunk. Then we did an x-ray. Well, they did the x-rays. And they found that she had a fracture in her knee. Now, right the lower leg, not where you usually would suspect that there'd be a fracture, like in the hip area or the wrist in older people. And then I happened to come in to do my consultation, and I talked to the son, and I said, how do your sister and your mother get along? And he said, he said, they fight like, like normal families do. I mean, usually that's not the first thing that you'd say, well, why she takes care of it. And so we put all these pieces together, even though the woman was demented. Really, the healing fracture in the tibia with the bruising, the patient's claims, even though she's, had some dementia, and then the very rocky relationship with the daughter made us think about physical abuse. But we would have never got to it without this sort of approach that we're outlining here. Okay, so sometimes people won't complain about different things. They'll just say, no, I just feel bad all over, or they deny the abuse. And that case underscores the importance of having somebody completely undressed. Sometimes if you see a patient who they should be having a cane or some sort of assistive device and they don't have it, that's sometimes the way that perpetrators exert power and control over their victims. And obviously we talked about a little earlier, observing the caregiver-patient interactions. We did a survey of medical examiners, and we said, look, why aren't you guys calling cases abuse and neglect? And they said, well, it's hard for us to sort it out. But one thing they all said that they look for is an exam that's inconsistent with the story. Yes?
What do you mean by the physical aids? Do you mean they take them away, like a walker?
Yes, they won't let them use their walker. They won't give their cane. And that's a way of exerting control over the victim. Because they have to walk slower, they have to lean on me, they can't, it's just, we've seen people withhold medicines in that same way. And how would you see it with medicines? With money even.
Selling.
Yeah.
Selling power wheelchair, selling assisted device, they do.
Well, here, that's right, they may go sell the device as well, and their medicines, by the way. So the medical examiners say, look, the one thing when we do call a case abuse and neglect is we look for a story that's inconsistent with what we're finding. Like somebody who says to me, well, she just fell today, and you see that the wounds are healed, or the fracture is healing, which couldn't have happened in a day. Obviously, we talked about how important written documentation is, but you know what, if we're going to help our legal colleagues prosecute these cases, help our APS colleagues put the cases forward, we're going to have to measure the injuries, use a body chart, and include patient quotes. And the photography piece, I can't tell you, how important that is. Now, what do we look for in the general exam? So they walk into the exam room, or you see them in the clinic setting, or you're at the nursing home, and a new patient is admitted, and so you look for evidence of weight loss. Sometimes they're anxious. Poor hygiene, patient odor. They don't look clean. The clothes are not clean. They appear malnourished. Like the woman I described to you earlier, they might be afraid of the examiner, or if there's signs of over-medication. I mean, you just have to have a sense and have a gestalt. And I think it's easier for us to take care of older people all the time because we know what's normal and sort of what's not. But whenever somebody seems a little outside the normal, our suspicion should be raised. Now, be sure that we don't mean that everybody who's malnourished is being neglected. The purpose of this talk is also to be able to call it when it's there and then refute it when it's not there. And so there's patients who have been suspected of being abused or neglected who had a cancer. And so that's why they were malnourished. That's why they appeared fatigued. And so, you know, this is a two-way street, and we want to be accurate in our designation of abuse and neglect. Traumatic alopecia, that means somebody's pulled their hair out. They're having hematomas, blood collections, and very poor oral hygiene. And although we see that sometimes in impoverished people, I don't know about this county here, but in the Harris County Hospital District, everybody has access to dental care. Now, it's not quick, you know, I mean, it's, if you have an emergency, we can get your tooth removed or something, but still, over time, there should be at least adequate oral care. The skin. None of these are surprising to you, but there is some data that you might find intriguing. Obviously, lacerations, abrasions, and bruises. Now, what do you know about bruises? Okay, what would you say? What bruise would make you suspicious? Or what about a bruise would make you suspicious for abuse, physical abuse? Color? What colors? And then we'll go look at
Like different stages, if they say it just occur and it's different, like if it's bluer or greenish, or and they say it happened today or yesterday, and
okay.
the color is different, then you would think that.
Okay, if they say it occurred at one time, it's different colors. Location?
Location on your body.
And what locations would make you more suspicious?
Under the arms, inner thighs, places that wouldn't take a direct hit when you fell, fingerprint-looking bruises.
So location and shape. Okay. And somebody else had something over here.
Size.
The size. You were going to say the size.
Size.
The size. Yeah, actually, that's very good too. Well, I tell you, there was a study by Dr. Mosqueda, and what she did was she got about 50 volunteers, normal people, to say, whenever you fall or hit yourself, call me, and I'm going to send a research assistant over there, and we're going to measure, we're going to look at your bruise. And she took paint chips from, like, you know, the Sherwin-Williams store. I don't have any stock in that, or any of the paint stores, right? And measured the wound, measured the bruises over time, over a 24-day period. What she found was that they were all different colors from day 1 all the way through day 24. It might start out, this is what we've always been taught, it might start out yellow, it might start out blue, it might start out pink, but they were all different colors, because some of it depends on how deep the injury was. And the change, it depends on the color of your skin. Certainly on darker skinned people, it's harder to detect. And so what she did find out, though, was the location piece. Most people that had a wound that, a bruise that occurred with a known event had it either on their arms or their legs. If you see bruises on inner thighs, abdomen, trunk, neck, or face, it's got to make you think about physical abuse. And clearly, if it's very large and there's a lot of extensive bruising, you really would have to think about this. Now, there was a paper written, that's referenced in your notes, Gresham and Langois. Anyway, they did a study, and it included older adults and younger adults, but no bruise in their study turned yellow before 18 hours. They didn't get out, they got out up to 24 hours in Dr. Mosqueda's study. And so we still have evidence to show that if a bruise is yellow, it's been longer than 18 hours. Hematomas are just a swelling of blood. If there's bites, and somebody mentioned the shapes of the bruises, and we'll go over that. And then burns in unusual places. One of the first mistreatment patients that we detected in our emergency room was a man who came in with a burn on his right forearm. And so the nephew was taking care of him and said, look, you know, Grandpa burned himself with coffee. Well, think about how hard is it to spill burnt coffee, right? If you're holding the mug on the back of your right hand, it's a little difficult. So that raised our suspicion, and we got a call from the patient's niece saying, no, my brother is abusing their uncle. So when the location is different. Obviously, pressure ulcers, never a good thing. Now, I have to tell you, we take care of patients all the time, and you cannot prevent all pressure ulcers. But clearly, if they're deep in multiple areas, we talked about that woman that had them all over her body, if they're bad enough to lead to death and there hasn't been the appropriate intervention, well, then that's indicative of mistreatment. lice or scabies, may be an evidence of self-neglect or neglect or welts. The pattern. Now some of these patterns, this is from a forensics textbook, and they have been determined for children. But somebody might be shaken if they had bruises on their upper arms, or if they were clustered on the trunk. You know, sometimes people will beat folks in places where you can't obviously see the wounds that wouldn't be on the outside. If the shapes are similar to objects like a belt. Restraints, evidence of restraints. I've had patients that came from nursing homes with wounds around their wrists and their ankles. Inside the thigh of their arms may be sexual abuse. And ulnar surface of forearms, it's a defense wound. So here's an abrasion, lovely picture. And this is some bruising due to being beaten with a wooden rod. See how it makes those tram line parallel contusions? Bite marks. Defense wounds from grabbing a knife. And then this is a manual strangulation. Now, musculoskeletal. I mentioned the woman at the very beginning that had the fracture in the unusual location. Or if there's evidence of multiple old fractures, that should be a clue. One woman that I need to describe to you was being cared for by her son and a woman he had met at a fast food restaurant. Anyway, she was brought in on Thanksgiving a couple years ago by another son who had come out of town to see mother. He was helping to bathe his very demented mother, and he was bathing her and he was washing her legs, and his hand came across something very sharp. Well, it was bone sticking out. And it was the lower part of the leg here, not the usual hip part, it was the lower part of the hip. And I don't know, the woman was completely delirious, probably due to pain. But the bone had been yellowed and dried. So here she had a compound fracture. That is, it was the broken bone and then it broke the skin. And nothing was done, and that didn't just happen right then and there. And the woman eventually died. We had a little trouble getting anybody to look into the case because they said, well, she's almost, she's going to die. And it raised some difficulties, and then it was in a different police jurisdiction, and we really had some problems. And it was interesting. In her X-ray of her leg, when we took to take a look at the fracture, up above she had a hip pinning. And that was the normal location where people have fractures that are older. The wrist, the hip, the vertebrae, maybe the clavicle, but not that lower part of the leg. You've got to think that there was some trauma there. And by the way, she had had that hip replaced 3 months prior to this event and had undergone complete rehab and was walking. And so there was some physical trauma there, I'm convinced. Neuro and psychological findings. As I mentioned in the first talk, cognitive impairment was really a risk factor, but so was depressed mood, flat or avoidant eye affect, anger, hunger for attention, unexplained changes in behavior. We've talked a lot about taking the history from community individuals, community dwellers, but what about in the nursing home, right? I mean, how are you going to pick this up? If somebody is being abused, this might be the only sort of things that you see. That's why nursing facility personnel can be very helpful in diagnosing these sorts of things because the behavior changes. Now, when we take a look at what might be in the genitourinary or rectal area, sometimes patients may have a rash. They may have an unexplained STD, a sexually transmitted disease. You may see fecal impaction or rectal and vaginal bleeding. Now, I don't mean to suggest that every time you go out and there's a fecal impaction, it means somebody's being neglected or sexually abused. But certainly, I mean, if it seems out of the ordinary, if it seems more common, if it seems despite treatment, it's something to think about. You know, we don't really have good markers for sexual abuse either in children or adults. There are not good forensic markers. It really takes us just having a high level of suspicion. So we have to look for these things, right? Look, if somebody's being sexually abused, they're not going to go after somebody who's cognitively intact, right? They're going to take somebody who's more vulnerable who can't report them. You know, a lot of times there's a delay in the reporting, and the medical examination is difficult. Obviously, if there's evidence like semen, you know, well, that would be helpful to have. I consulted on a case where there was a white substance on the woman's leg in a case where there was alleged sexual abuse, and nobody sent anything for a sample. We would have been able to clear that up right away, and it was never sent. Obviously, if there's bruising in the pelvis or the perineum, that's new, that's suggested. But also other evidence, there can be bruising of the hard palate with forced oral copulation. Abdominal bruising is very common from somebody who weighs more than you lying on top of you. Other secondary evidence, that there's vaginal discharge, sexually transmitted disease, as was mentioned, or if there's blood. That should be investigated. Now, sometimes you can detect that there's been some sexual abuse if all of a sudden the patient is now agitated or anxious at the time of bath or perinatal care, that everything was fine up until that point. Sometimes they demonstrate these reenactment behaviors, so they'll repeat the words that were said to them during the act. You know, lay still and don't move. And you might have a demented patient that recounts that. And then if they have a fear of a male staff or examiner, certainly women can sexually abuse others as well in the literature, and still make up the greater percentage of sexual abuses. Now, how do you tell? I mean, when the woman came in accusing her daughter of abusing her, how do we really know that this bruise didn't come from a fall, and you know that this wasn't just a delusion? And basically, you can't just use the physical exam. You can't use it in isolation. In that case, we used physical exam, X-ray, as well as collateral history from the son. And that has to be done. And we should think about, you know, there's not a lot of literature on the laboratory and evidence in physical abuse, but certainly we have to put everything together as good clinicians. So, when creatinine in the labs, physicians might order to look for dehydration. Check for diabetes to see if it's being managed properly. You can check blood count levels and bleeding tests like the PT, PTT. Liver function tests, you might detect alcohol abuse. Obviously, thyroid function test. 25% of older people have some thyroid disorder, whether it be hyperthyroidism or hypothyroidism. That might explain the weight loss, and it might not be neglect at all. New albumin is important, and then the fractures. I mean, you could get a bone density study and see if the person's having fractures, yet they have good bone density. Why are these fractures occurring then? And obviously, look for urinalysis to be sure that that's not the reason they're confused. And so we have a great deal of difficulty in detecting things like this. Lacerations versus skin tears. Now, anybody who's worked with elderly people, maybe you have elderly parents or grandparents at home, have seen skin tears. There's actually been a study of skin tears in the literature. What they did was, over a year, they studied one nursing home, all the skin tears that occurred. And where do you think the most common locations were? Arms. Arms. 75% were in the arms. The other 25% were on the legs. There weren't skin tears anywhere else. So that's a clue. What do you think the average length of the skin tears was? It's actually less than an inch. The average, some were that large. Less than an inch. So when you see a long skin tear, long lesion. That should make you suspicious. What do you think the average number of skin tears that the elderly residents of the nursing home had in a year? 1 was the average. So if you see somebody with multiple skin tears, repeated skin tears, in your facility or during an investigation or in your exam room, then you need to think that this is more likely to be abuse. Now, we talked about the issues with bruising, multiple bruises. I mean, clearly if you do see multiple, that should raise your suspicion. But you've got to look and see, does the person have a coagulopathy? Are they on Coumadin? You know, with age, you lose soft tissue in the skin, and the blood vessels become more fragile, and so that's what leads to more bleeding. Multiple fractures versus osteoporosis, and we discussed that. Now, is the patient depressed because they have major depression, or do they have a depressed mood because they're being abused at home? I mean, if you're living in a situation like this. And then the woman that we talked about, she reports abuse, or is it just her dementia? And really, it's just a delusion. We've had cases where somebody refused to leave the emergency room, and if you refuse to leave a busy public hospital emergency room, there's got to be a problem. And so she just refused to leave. She said that somebody at home was physically abusing her, and so we did a complete investigation. APS went out to the house, they spoke to collaterals, there was no physical evidence of it, and so she was discharged home, and we did a follow-up visit, and there was no further complaints of this. We owed it to her to do an evaluation, but there was none. And then is confusion due to the head trauma, or are they alcoholics, or they have a brain met or something that's causing the changes in the head? And so what are the long-term consequences of abuse? I have to pose this question to all of you. What do you think comes first, the depression or the mistreatment? You think the mistreatment comes first? You think being old is depressing?
What's the alternative?
Yeah. Not
Caregiver depression comes before the abuse. No. And we're going to do a study where we follow people over 5 years, and then we have a team of social workers from the University of South Florida. They're going to take histories that go back into their past, their prior life and the prior events. I think when we have been able to go back into the history, it seems like the depression occurs before self-neglect. But I'm not sure that it's not the other way around with the other forms of mistreatment. You get hit enough, you get beaten down enough, you feel like you can't get out. The older you are, the less financial resources. You can't leave and go get a new job, and so probably that it occurs the opposite direction. Obviously, anxiety, anorexia, sleep changes, regression, and we've talked about death. You know the one woman I told you that was afraid to be approached by by our medical team? Once she started to get well again, she was very regressed. She couldn't speak because of a stroke, so she would come up, and the way she greeted us was to hug us like a child. It was very interesting how regressed that she had become. And not all stroke patients do that. And just because you can't communicate doesn't mean you go up and hug everybody to say hello. But she was that regressed due to the abuse by her daughter. And so in summary, abuse is not easy to recognize. And we must keep the possibility in our differential, and obviously thorough history, adjunct testing, and psychosocial evaluation are important. And I want to just take 2 minutes, because I know we just have a little to 2:45 we go to, right? We are designing a study right now that we're going to submit to the National Institute of Justice that is going to come up with criteria for death due to elder mistreatment. And I'm just curious what all of you think. If you had to say, because we want to come up with something at the end that gives a medical examiner a list that when he or she sees these findings and you have a deceased who's been reported to APS, that he can call it elder abuse and mistreatment, because you know what, they're not going to be able to prosecute these cases unless we have something. So what would you want, if a death was due to physical abuse, what would you want to see? What kind of criteria would you include in there? Yes?
I guess, you know, if there's bruising, injuries, whatever, incompatible with any history of care or problems or accidents, that would be evidence that it was abuse.
Yeah, and so that maybe should be a checkbox, you know, on a form somewhere. Is this compatible? Are the findings compatible with the history you have? I mean, that may be the most important thing. Other things. Yes.
That malnutrition and bed sores are not a part of an actual death necessarily. A lot of the times you find that the clients have been neglected, they live long, unfortunately sometimes they live long enough where the medical examiner, or we say it was due to neglect, they live maybe 3 or 4 months, it becomes a natural death later on. So when we try to move it to law enforcement, it's no longer the death, they can't connect the death back to the abuse and neglect.
Yeah, I mean, what's the statute of limitations on a bed sore, you know? Well, if you live 3 months with it, that means it didn't cause your death. I mean, that's a very important point. That's an excellent point. Another.
Do they routinely do toxic screens and check to see if, you know, I'm sounding like the vicious son-in-law or something. What if you wanted to poison somebody and get rid of them over a period of time and let the arsenic build up in your system for a while, or God knows what? I mean, that would be maybe evidence of purposeful poisoning.
You know, it's funny because when a child dies, they have a pediatric tox screen they do automatically. And they don't do any of that for adults. They don't do any of that. And there's even a pediatric toxicology registry where you can look up what this level was that killed this age child. That's what we would need here. There was a question.
There was a speaker at one of the APS conferences one year that talked on, you know, the gray murders or whatever, and they went back and they dug up a lot of natural death, and they were finding a correlation between the reporter. Who did they live with? Who's reporting this flu? You know, they died of respiratory distress or something like that. And it's all natural death, but they were going back and trying to get, you know, grants and research money to go dig them up. And they were finding, you know, lived alone, at home, with son, died of natural causes.
And they look old when they're dead, right? They have got gray hair, they just look old, you know? So bed sores are normal, that's, you know, certainly flu kills older people and they don't know.
Or dehydration when you have a peg tube. That's always my favorite death.
Yeah.
I don't understand that.
And then the last thing too is when there's what some people do is they hide the abused or neglected person in a hospice. We're part of an elder fatality review team. Oh, you've got a story about that?
The other day I saw someone who came in for cath. Actually, we were changing a G-tube because for 3 months the skin has been excoriated because it's been leaking. In 3 months of the tissues, first of all, she had a burn scar that's been old, and then she's got this excoriated peg tube site. Then she's now, when I'm looking at her and assessing her, she's got a decubitus here. She's living at home with a family. Her perineal area is just excoriated. And the hospice nurse is calling me, and she makes a comment that says, well, I wish I could convince the family not to put the peg tube back in. It just didn't sit right with me. And when I'm trying to get the history of the medications that the patient's on, the daughter is giving, well, no, she's not on that anymore, but it's on here. And very disorganized about her care. And I'm asking, have you been putting barriers on the skin? Have you been protecting it? And so
if you didn't raise that issue, right, the case would go to the hospice, they pull out the peg tube, patient dies, medical examiner sees hospice case, patient died, good, case closed. And that's just unless you raise the issue.
right, and it didn't dawn on me, and you know, to ask these questions. I mean, the patient, while she didn't have a good grasp on time, she knew who she was and why she was there. She'd had strokes, but couldn't take care of herself physically, so she was dependent physically. But mentally, she was there. And, you know.
So just pull the peg anyway. Yeah. See, it's No, we're gonna have to have criteria for this. We're gonna have to get, yes.
Would the top screen include like natural things like vitamins and herbs?
That's
Because
an
I
excellent point.
have a client right now that her son is taking care of her. And, well, she's in the nursing home now, but he was taking care of her. And every time she's in the nursing home or in hospice, he inserts into her peg tube, you know, it's some kind of liquid, and they're not sure what it is.
Arsenic. I mean, you could get vitamin A toxicity and kill your liver with that.
Like this, that he's been reading to see what he needs to give her to make her better.
Wow. She's not an experiment, you know.
You know, and not doing that under a physician or a nurse practitioner's direction is not a good thing.
They keep discharging her because it's,
Yeah, sure, because better not do, that would be the difficulty with the tox screens though. What do you screen for? And older people, how about just start with the medicines they're on to see if the level was high level or there was undetectable level. But that's an excellent point for natural things. Yes.
I think a skeletal x-ray should be part of the file also.
You think a skeletal x-ray should be what?
A part of the
Like a
question that you
baseline?
raised, yes.
Yeah.
You know, why can't the medical examiners do that? Why couldn't they just put them through an x-ray machine, you know? It doesn't cost as much to read there.
That's true. A lot of the palliative care etiology now as well. These are, we're born to die. This is, you know, this is going to happen. Why should we spend valuable resources investigating this when we should spend it on people who have time left to live? This is what I get.
That's a whole, you know what, that's a whole topic, because the question is, do we value our senior citizens? And you know what, if you start, you know, at age 55, if it looks natural in the Harris County Medical Examiner's Office, they are not going to do the investigation. 55. Now, I'm not too far away from 55, and that looks like an awful young age to start to write it off. And so right here's the point. Well, if you say, well, after age 85, we won't do it anymore. Well, then, what's the difference between 85 and 75? Well, now we're up to age 55. But anyway, one last there was another comment?
Just a comment on the way families are perceived as far as taking care of their older parents. It's almost like chattel. Well, she's old, and if he wants to pour something, that's her son, and he takes care of her. Or I've had doctors say, well, she brought him to my office because she was putting dish soap on her face, and he said that the Aerosep wasn't on her drug formulary, and yet we have a totally incapacitated person who comes with somebody who can have disclosure rights, but they are making decisions, they are putting stuff in their little peg tubes, it's their child, this is mom. It's like chattel. It's like the elders' chattel. There is no value. Although they do hold all of our credit, the good credit, the majority of the votes and money are held in that demographics, but we don't treat them like that. It's that kind of bias at the medical examiner's office, at the nursing homes, at the doctor's offices. I'm sorry, but doctors get really mad at me when I tell them that if they're incapacitated, then you can't just use the son in the doctor's office to make a decision.
Well, you know, that is a bigger issue, because that's the whole point of having the geriatric education centers here, to try to raise the awareness of all the things that are important and affect elderly people. And you know what? We're all going to be there, hopefully. All right, so post-test question, list at least 3 findings on history and physical examination which suggest the patient has been sexually abused. Are these different than the pre-test questions? Well, that's the trick. Oh, yeah. If you know that, at least you're paying attention. List at least 3 findings on history that would suggest the person's been this looks like the old set, the old uncorrected set. Okay, list 3 adjunct tests would be helpful in differentiating. Well, you know what? Just look back at the first questions on your thing and answer them. What happened here? Okay. Thank you all very much. Appreciate it. Enjoy the rest of the conference. Thank you all for coming. And now it's time for a break.
APS, and the reasons that APS needs to get involved with us as health providers and members of the legal community. There are a number of national associations and professional groups that recommend it. The American Medical Association, the American Academy of Family Practice, the American College of Obstetrics and Gynecology, the American Nurses Association, and ACEP all recommend it. JCAHO, which is the accrediting body for hospitals and some other institutions, requires protocol in all ambulatory settings that there be some policy related to the reporting of elder abuse and the management of elder abuse. Elder abuse is not uncommon, as we've heard all day, that it's a growing phenomenon in our country. And with our aging population, we are going to see more and more of it as we go along. And intervention can be effective. Is intervention easy? No, it's not. It's not easy. It is not easy to have a team institute, as APS in Region 6 will attest to, as will we. I feel like I'm speaking to the choir here because there are a lot of APS folks here, but I want to let our audience know what you guys can do and will do, and also I want you to join in with me in telling our other participants about what you can and will do. This is what we call our radar. When a person comes into a physician office or into a medical setting, there should be a routine screen of an older adult for elder abuse. Be aware that it might be taking place. Ask direct questions of the patient when they come in if you suspect elder abuse. Document your findings. As Dr. Dyer mentioned, that is extremely important, and we're finding out if we ever intend to prosecute perpetrators, we're going to have to get much better at documenting the conditions. Assess the patient's safety, and then make referrals to the appropriate social service or assisted device or occupational therapy or physical therapy departments. Utilize the resources that are available. Know what the resources are that are available or in the medical community for you to use, and report elder abuse. You know, physicians, although they do most of the reporting, medical providers do most reporting of elder abuse in the state of Texas, the numbers are very, very low. Doctors, nurses, others don't want to get involved. They're afraid that there'll be repercussions. They are afraid they might be sued by the family if allegations are unfounded. There are all kinds of reasons why people don't report. And a lot of times it's just denial, that a medical practitioner thinks this could not be happening to an older person in my community. True or false? Texas law requires healthcare professionals to document elder abuse. And all other states have mandatory reporting laws. True or false? Right on both counts. Texas has a mandatory reporting law. Not all states have mandatory reporting laws. 44 states and the District of Columbia mandate reporting of elder abuse. The states that don't require are Delaware, North and South Dakota, New York, of all places, with New York City, and there's one other that you'll talk about it. She'll talk about it in hers. You'll be surprised. It's in your book. I can't remember. You know, look at me. You know why I can't remember. Okay, this is a case that the physician author of this this module came across. She's a 76-year-old female with a history of stroke. She was paralyzed on her left side, or on the right side, I'm sorry. She tells you that no one is turning her or cleaning her regularly. This lady lived with her daughter. Her daughter traveled a lot. This lady was able to articulate and could tell people that she wasn't being taken care of. So but she could not do anything for herself. So if you have a daughter who's traveling a lot and you can't do anything for yourself, what's going to happen? You're left alone. So this case, how do we document it? What happened with this case is that the neighbor knocked on the door for some reason, and the door was unlocked. She opened the door and she noticed this terrible smell coming from this apartment. And she went in and she found the lady in the bed in this state, and the odor was coming from these infected decubitus ulcers. So she called Adult Protective Services. So how do we document this case? How many of you in here use SOAP notes, what we call SOAP notes? Doctors, nurses do. SOAP notes are the way in which we document medical findings. And they're very good even for our APS workers and others to use as well, because it's a very organized way of documenting. We look at we looked at subjective, objective, assessment, what we would do on an assessment, and how we would make a plan. Subjective. Okay, what does the patient tell you his or her symptoms are when they come into a doctor's office or medical provider? What did this lady tell her neighbor? My daughter doesn't take care of me. She doesn't clean my sores. She travels a lot. Those are subjective things. Things that the neighbor might notice. The apartment was dirty. Those are not documented as factual. They're the subjective view of the neighbor. What APS first sees, that's their subjective review of the scene. The perpetrator's information. So what does the daughter say? Well, I travel. What else do you expect me to do? I can't take care of her. The surrounding circumstances. What other circumstances are there in this case? Are there unpaid bills? Are there no means to get extra support into the house? What are the other issues that are involved in this case that we really haven't documented, but that are told to us or we find out? The objective finds, obviously, the objective finds is this woman had huge infected bed sores. In our interactions with others, what do they tell us that we know that we can document, that we can validate? The physical signs of injury. What is the objective view? And objectivity too is what can we document? What can we prove? The assessment. What kind of assessment do we do? In this lady, we would probably assess her decision-making capacity. We would assess her environmental situation. We would assess the daughter's situation. We would assess finances. We would get all of this information together. And then in determining the lady's decision-making capacity, you've heard this repeated several times a day. We would have to determine whether we respected her autonomy. People have the right to be autonomous in their decision-making until they do not have the capacity to make their own decisions. Versus beneficence. Sometimes we collide with Adult Protective Services in this. Adult Protective Services has always gone by the mandate, we want our clients to have autonomy and be placed in the least restrictive setting. That's very important. That's one of their hallmark. Versus beneficence. The physician says, first do no harm, do good. In doing good, we might have to maybe consider the patient's autonomy, but act in the best interest of what we see as the medical needs of our patients. So there's sometimes quite a bit of kind of collision there. When we first started our team program, I mean, we had these big fights over, you know, APS wanted to do this, we wanted to do this, and finally we had a medical ethicist come in and talk to all of us and educate us about just how that could all fit together. Assessment. Assessing decision-making capacity, discrepancies in stories, what are our suspicions versus what is fact, what are the issues of safety that are relevant to this client's or patient's circumstances. Right? When we assess the safety, we want to know, is the client safe right now? Are there weapons in the home? We always ask, one of the first questions we ask on house calls is, do you have a gun? And our nurse practitioner, Sabrina Pickens, has this wonderful slide of one of her patients. This lady, it must be 99 years old, she looks it, but she is spry as can be. This lady has this huge, big old Western, OS gun. And the lady has the gun in her hand, and she's holding the gun right here, and this little 90-something-year-old lady holding this gun right here, and she actually had business cards made of herself holding that gun, this little 90-some-year-old lady, and she calls herself the gun-toting granny. And so I guess her message is, you better not mess with me. We assess whether there's a threat of homicide or suicide. We do that. Adult Protective Services also does that. And who else is involved or can be involved in helping us resolve this case? We have a plan. We can make referrals. APS can make referrals. APS writes up their reports and does a huge very, very detailed assessment of the client's situation. And then can identify resources and put resources into play. What I want you to do right here is to write down, for all those non-APS folks in the room, I want you to write on a piece of paper, what services do you think APS in Texas can provide? Just guess. I mean, you don't have to be right. But just tell me what services you think APS in Texas can provide. Okay, anybody want to take a volunteer to tell me what they came up with? Or tell your friends here in the audience, what did you come up with? What service?
I put placement, financial assistance, guardianship, and referrals. Like to hospice or...
Right, true. That's true. You APS guys, correct me if I'm wrong on any of this. Okay, anything else? She said assessment, financial, anything else?
Emergent medications.
People haven't had their medications.
Right. Emergency medicines. That's correct. Anybody got anything else? Okay, turn to Module 7, page 11 in your book. Now this was developed before APS reorganized a couple of years ago, so it may have changed a little bit. But that, and you APS workers in the room, tell me if there are other things that should be added here. APS can provide social casework services. They can advise the clients or the perpetrators or the caretakers. They can advocate on the patient's behalf. That is their main job, is to advocate for abused, neglected, and exploited elders. They can confront perpetrators of abuse or neglect or exploitation. And they can assure that the clients receive all the benefits and entitlements that they are eligible for or have a right to. They can make referrals for medical assessments and treatments. They make referrals to us all the time. They can make social service referrals. They can make referrals for respite care to reduce caretaker stress. They can make referrals to family violence programs, housekeeping, personal care, nursing. And if eligible, the APS caseworker can arrange a lot of this for the patient. And they can arrange for a protected payee for the patient or the client. We have in Texas, we are very fortunate in Texas because most other states don't have this. We have money to pay electricity and light bills and water bills and telephone bills and to buy food. Our APS office in Houston has a pantry, and everybody brings food and diapers and Depends and lotions and to stock their food pantry and their clothing pantry. And we periodically will have something in our hospital where we bring things and give them to the APS pantry. It's not big, they can't do a whole lot, but they do something. APS can provide emergency shelter, as I said, food, clothing, medication, medical supplies, assistive devices. And they can provide legal intervention. Now, this is kind of the last resort. Only in 1 in 10 cases does this usually happen. It might be becoming more frequent in APS because the issues of capacity are becoming more and more of an issue with older people. And so they may rely more on the legal community in future. But they can remove to safer surroundings. We call this emergency removal. Obtaining protective orders to limit the perpetrator's access. To obtain mental health orders where a person can be admitted to have a mental health assessment. They can go for guardianship of a person if necessary, and go for criminal prosecution, although this is rare. So those are some of the things that they can do. True or false? Drug and alcohol abuse are the leading causes of elder abuse. Are the leading causes of elder abuse. That's false. Drug and alcohol abuse they're not causative of elder abuse, but they're a contributing risk factor and one of the leading risk factors for elder abuse. APS, and you should stay informed of the resources available, have information ready to offer. APS if anyone calls, you if you're a medical provider or practitioner. Facilitate access to services, and make follow-up appointments for the patient if necessary. We have a policy in our clinic that when we see an APS patient, we automatically make an appointment for that person in 2 weeks so that we can follow up. And if that person doesn't show up in 2 weeks, then we start making telephone calls. Different laws in different states, we talked about that. Information requested from healthcare professionals. If you anybody in the state of Texas, if you make a report to APS in good faith, You are immune from repercussions from caregivers, perpetrators, family members. You are protected if you make that referral in good faith. I've had to make referrals on my neighbor, but I made those referrals in good faith, so I was protected. And you are the same. It's the same for you. So don't be afraid. Don't use that as an excuse that you're afraid you might get sued or get into trouble. You notify the patient if you're going to report them. Medical providers need to notify the patients and the family members. I am required by law to report this to Adult Protective Services. The information requested from the healthcare professionals is extremely important. Again, anonymous. You can be anonymous if you like. It cannot be revealed to anybody else that you've reported, and you are free from immunity if you make the report in good faith. The main goal of Adult Protective Services is to get elder victims into nursing homes. True or false? So APS does investigation, assessment, and develops a service plan. And with the Team Institute, they develop a service plan from their end, usually mostly on the social aspects, financial aspects, legal aspects. We do the service plan from the medical view, but we do it all together so that we can all be checking on one another and making sure that we get what we recommend in the service plan is followed through with. APS, I mentioned that, purchase, service, legal interventions, referrals, and social work. APS has limitations. Clients' wishes and interests supersede those of the family and the community. And plans must maximize self-determination at all times. We have cases